and the TCOM says their oxygen in that tissue is 30. That's not going to heal. You have to have over 45 millimeters of mercury of pressure to heal.
What's a TCOM?
That's an electrode we'll put around the wound. It measures the amount of oxygen. In the chamber, we can do it, and it can go up to 500, 600, 800.
Now, can you get too much?
Well, we are actually allergic to 100% oxygen. You can have a seizure. 1 in every 100,000 treatments, you can have a seizure. So then we have them breathe room air while they're in the chamber.
Hello. Welcome to the Dr. Gill Show. This is where we talk about medical matters that matter to you. My guest today is my friend, Dr. Kim Jamieson. Welcome to the show, Kim.
Thanks for having me.
Kim is a medical doctor. She's a colleague of mine here at Boone Hospital Center in Columbia, Missouri. Kim has a very interesting, lengthy training that has led her to become the medical director of the Boone Hospital Wound Healing Center. Did I say that right?
That's how we call it, yes.
That's what you call it, yeah. So Kim grew up here in the Midwest, and as a child, she grew up in Kansas City, hence the Kansas City Chiefs t-shirt and regalia. We love Kansas City Chiefs here. We've had like 2 or 3 world champions. Or we've had 2,
actually,
now we're going through a third one.
No, actually
now.
4. No one remembers the one with Lenny Dawson.
Years ago.
Yeah.
When I was a kid. No,
Yes.
I remember that. I remember that, but we've had 2 in a row. We're going for the 3-peat right now.
There we go, yeah.
So anyway, so everything is Chiefs around here, all Chiefs all the time. I love our team. So that explains that. Now, Kim, you went to medical school here at what we call Mizzou. Got your MD here at Mizzou, University of Missouri. And then you went on, did a residency in internal medicine.
Yes.
That's 3 years usually, right?
Right.
And then you did something called a fellowship in nephrology.
Correct.
That's the study of the kidneys and blood and high blood pressure and all
Lots
kinds
of
of
diabetes.
and a lot of diabetes, because the kidney is an end organ for damage from diabetes. And were you practicing nephrology for a while?
I was with Keller Winkelmeyer. We were partners for quite a long time until I had to have another cervical neck fusion. So
Neck fusion. Why did you need a neck fusion?
I actually had a motor vehicle accident when I was a 4th-year medical student and broke my neck.
Yeah, you broke your neck. Now, I came to the Midwest about 18 years ago from New York, New Jersey, to the Northeast, right? And when you have something go wrong with your car, you have an accident, right? And I'll never forget, I was here starting to see patients 18 years ago, and this young lady was across the desk from me, and I'm talking to her, and she's had scars and surgeries. And I said, wow, looks like you had a car accident. She goes, no, I had a wreck. I said, you know what? You're right. There's an accident, and then there's a wreck. So you had a wreck as a 4th-year medical student, and you had your neck broke. How did you survive?
Well, I was driving my mother's Delta 88.
Big Delta 88.
They were all steel back then.
Big V8 engine, heavy car.
Yeah.
And
Saved my life.
Saved your life. So did you have to have surgery and immobilization and a long recovery?
Well, this was before CAT scans. So there was some x-ray changes, but there was nothing to determine that I had broken my neck. So I walked around for 6 months with a painful neck until Mike Ditmore decided that we were just going to go in and look and see what was wrong. And he was the neurosurgeon that fused me.
So they just had plain x-rays, and the way to find out if you had a broken neck was to go in and look? Did I hear that correctly?
I was at the university. Actually, Boone had the first CT, but it wasn't available to me. So,
Goodness.
Yeah, it was.
Did you have one of these fractures where it could have slipped and you could have died if you fell wrong?
Well, I turned my head one day and I lost control of my left arm, and so that's when he decided he was just going to go in and look.
Go in and look. Oh my goodness! So you said you had 2 surgeries.
I had two fusions then, and then subsequently, when your neck is broken, above and below is unstable. So then I had another fusion in the 90s. So.
Oh my goodness, Kim. Well, I'm so glad you're alive, and you saved all your marbles. Clearly,
pretty much, yeah.
All your marbles. Yeah. So here you are, a nephrologist, and in fact, Keller Winkelmeyer's coming on next week. We're going to talk about high blood pressure with Keller.
He takes care of mine.
Yeah. Everybody likes Keller, and he's a musician. Oh, it's going to be a great conversation. So, Kim, what did you know when you were a child that you wanted to be a doctor?
I did. I don't know why, because there's no one in my family who was a physician until you look into the Civil War.
Well, now, was there a moment, when I talk about all the time, I knew I was a surgeon at age 5. So I was starting to operate on my stuffed animals. Did you have a moment where you were playing doctor, you put a white coat on or a stethoscope, or you cured your puppy or something? Was there some moment where you knew you had a feeling you want to be a healer?
I just always had a feeling, and then I had a great GP. That's when they used to take out tonsils, deliver babies.
The general practitioner would do everything, surgeries, even C-sections. Sometimes these guys and sometimes gals did it all.
So I thought a lot of him, and I thought that would be. You always hear about, I want to help people, but I really did. So
it was in your nature, and you had a good role model.
Yeah.
So that's interesting. Some people did find out later in life, like for example, let's say you didn't know and you had your neck fracture, and then you're in rehab and surgery. You go, hey, this is a neat job or something. There's these formative moments sometimes. So here you are, a fully trained nephrologist. So was it somebody or some event that got you interested in wound care?
Back in the 90s, there was a vascular surgeon, Chuck Barbie, and he told me he called me Spike. He said, Spike, you need to get into wound care. That's going to be the next specialty. So started looking for conferences and going and reading the little bit of literature that was out there. And the first conference I went to probably had 200 people, and now there's the SAWC is in Las Vegas and has thousands.
Thousands in that big convention center in Las Vegas. Yeah. So let's talk about normal healing and then work on our way over to non-healing and wound issues, which is clearly a problem. Let's say you're a kid and you skin your knee. It bleeds, you wipe it off, mom puts a Band-Aid on maybe, and a week later, it's pretty much healed and it's gone. We don't even really think about it. I don't think about it. We all get little scrapes and scratches when we're kids. What happens? How does the skin seem to magically heal itself from a wound in a healthy kid?
Well, the skin is actually the biggest organ of the body.
For a good point. People don't realize your skin is an organ.
And it has electrical properties, and you get a cut, a scrape, whatever. The skin starts sending signals to the brain starts sending cells down to wherever the wound is, and you get all of these millions of cells growing in to heal up the wound.
So there's a communication. Yeah. So the pain and whatnot sends signals, and signals go back down, you're saying.
Right.
To create that redness, and this cascade of healing events. Now, I did a little bit of research for this, Kim, and it seems that some people say there's 4 steps. Okay, they said the bleeding stops, or at least we've gotten that far, right? And then there's inflammation. I think that's part of the process you were talking about. And this is good inflammation. You want things to swell. You want blood to come in. You want it to get red and sore because it's bringing in this soup of chemicals, chemoattractants, cytokines. You tell me if I'm wrong.
Macrophages, growth factors.
Yeah, there you go. Now, this is the stuff that I'm sure you know way better than I do. And then the third phase is when connecting cells kind of crawl in. I think they're called fibroblasts, and they start setting up bridges and collagen and protein and lattices and whatnot. And then there's the final step they call maturation, Or I guess it just kind of settles down.
Scarring and remodeling.
Scarring and remodeling. And that just happens. You don't have to think about it. And if you're young and healthy, there's plenty of factors and nutrition and stem cells and all that stuff to heal up. And then I noticed a skin knee. You barely even know it was there a few months later in a kid.
Unfortunately, my practice doesn't see many people.
You're not seeing that, right? So what I'm doing is I'm starting out with the easy ones where, you know, for example, I have a friend with terrible asthma, you know. I breathe. I don't think about it.
Yeah.
When he's having an asthma attack, every breath he thinks about. And when we're healing normal, it's no big deal. I cut myself shaving or whatever. It's gone. I don't even think about it. Now, let's move into why your clinic is so important. There are lots of times when people don't heal and they have wounds that don't heal, and that can be a big deal, can't it?
Oh, my goodness, yeah.
Yeah. Keeps you busy for decades. Yeah.
We've grown our practice from, we established the wound clinic in the 1701 building in Halloween of 2011.
Wow.
And we've had 2 increases in our building. So we've taken up the 3/4 of the first floor of 1701.
Wow. So your clinic in one way or another has been around for at least 23 years or longer.
Yeah, we had a moving clinic in Boone prior to that. We're just a corner where we could set up and help folk, and we convinced administration that wound healing was a necessary facility, a subject to a clinic to have.
So the numbers spoke for themselves. The demand was so high.
We took Dan Rothery to
You're a former CEO.
to Ohio to look at a wound clinic there, and it was called National Healing at the time. They managed wound clinics, and he was convinced that that was something that Central Missouri Boone Hospital needed.
We really needed it. So let's talk about the demand and what are if there's anything typical or the usual types of cases you would see that have wounds that don't heal or are having problems.
I saw 35 patients today.
35 patients today.
Yeah.
Wow, that's a long day.
So
wow.
I have a great staff.
Yeah, having a team is so important, isn't it?
Yeah.
A combined experience and teamwork. Very, very rarely can we do this alone.
Oh my goodness, no. And I just have a great bunch of people that are very kind. You're going to find that wound clinics, people that want to do wound care they're a different folk, because when you're looking at diabetic feet and nasty wounds, and my peers make fun of me and say, why are you doing this? I mean, my friend Michelle Diaz-Arias, she's a GI doc, and I tell her I see more stool than she does. Yeah.
Yeah, because healing around ostomies is one.
Well, and folk that have paralysis and they don't have control of their bowels, and then we have pressure ulcers on the bottom, and
Yeah. All right. So these are some of the main categories. So let me cast a broad net here and go just through some general categories. One disease that really impedes healing is diabetes, isn't it?
75% of our patients are diabetic.
Are diabetic. So blood sugars are high, blood vessels aren't healthy. What else goes wrong in a diet? What is it about diabetes that slows down or prevents proper wound healing, Kim?
Well, unfortunately, and with newer medications and the blood sugar control now, that the devices they can wear on their arm and they can know what their blood sugar is.
The pumps and whatnot, yeah.
So, but as you have diabetes, you develop neuropathy, so your feet, you can't feel. I've had a guy that went out hunting, and one of those small super balls that they used to sell.
Yeah.
That super ball was in his boot all weekend long. He
a super ball was pushing on his foot, and he didn't even feel it.
And he takes his boot off 2 days later, and his foot is black. So he never felt it.
Oh my! So a neuropathy, folks, means there's a pathology of the nerves, and you don't sense the pain.
blood sugars are high, so your blood is just like syrup, so it can't get to the wound to heal. It decreases your ability to heal. The signals to your brain, the macrophages, all of the cells involved in healing are slower to heal.
So this communication
Yeah.
you were talking about is impeded as well. So it's blood, it's innervation, all the fact that the high sugar impedes all these factors. So you get a non-healing wound.
And then diabetes causes kidney disease, and probably a good 50 to 60% of our folk don't have good kidney function. Therefore, they're not going to be able to heal a wound.
So what is
well.
it about poor kidney function that impedes a wound? The kidney's here, but the wound, let's say, is on the foot.
Well,
How does the kidney
kidneys are
affect
good
the
at
foot?
they're the sewer treatment of your body. So if they're not
Right.
getting rid of all those toxins just hang around and just prevent you from healing. You have, as you get more uremic, it's when the blood isn't, then you start scratching, then you can cause more wounds. My folk some of the patients are blind, so they have difficulty being able to
even see.
Yeah.
So if you can't feel it, you can't see it. Boy, that's going to be a problem. So having the toxins, uric acid, and all these other creatine, all these other waste products that the kidneys would remove, stay in the blood, impede wound healing, damage the body.
With kidney failure, you get an elevation of your phosphorus level, and that makes deposits in your skin.
Phosphorus. I remember that as a student. Yeah. Phosphorus, and they took muscle cramps and checking aluminum levels. Boy, those are old memories. I hadn't even thought about that in 20, 30 years, Kim. So kidney, poor kidney function, renal function. So that's where I bet you being a nephrologist is very valuable. There's a connection. Okay, I see it now. In the expertise of one helping the other.
So when I was doing nephrology full time and I was working with Dr. Barbie, Keller was my partner, you saw all of these folks that were really sick. And so I'm just kind of used to it, but it's when one of the other physicians came in and said, boy, these patients of yours are really sick. And I had to think about it because this is what I've been doing all of my medical career.
Yeah, that's just you are normal.
Yeah.
Yeah. Yeah. My goodness. So diabetes, blindness, renal failure. Are there any other big categories? You had mentioned ostomy. Let me explain what an ostomy is. Bowel goes from mouth to anus. There's one direction. If there's a tumor, a blockage, a disease or something, sometimes you need to divert or bring the bowel up, generally to the front of the abdomen, so the bowel contents can come out, generally into a bag. Now, that bag has to be glued to your skin or attached to your skin. And I don't even know how it seems to me every time you peel that thing off, you're horribly damaging your skin. So you have bowel contents coming out. And if it's your small bowel, it's irritating fluid with digestive enzymes breaking down the skin and whatnot. And some people, bless their hearts, have permanent ostomies. They're not going to hook them back up. They're not going to reverse that in a number of cases, in a lot of cases, I guess.
And there's some skin issues that happen with colon issues, and then you get wounds around the ostomy. And we work with dermatology sometimes for that. We work with dermatology, cardiology, vascular,
general surgery, colorectal surgery, working with all these specialties.
So we have a couple of the nurses are wound and ostomy certified. Our program director, Amy Barrick, is wound and ostomy certified. I never learned any of this in my medical school or my residency or my fellowship. So this has been training on the job.
Yeah, we're old enough to, when I was younger, there was, I'm a reproductive endocrinologist. When I was in medical school, there were no fellowships in reproductive endocrinology. You did some urology, you did some medical endocrinology, and finally they came up with a fellowship. You came up in a time you just had to learn.
Yeah.
From other people and the small.
Well, wound care
groups.
First started with nursing, so.
Oh, so tell me, is there like a history to wound care? You kind of march me through. Obviously, we've been taking care of wounds for millennia. Battle wounds
and leeches are
And
still
leeches?
used today. They're
Really?
medical maggots, but Missouri maggots are cheaper, and we see them all the time.
Matt, you mean they're naturally there? They started on a fly came by, laid eggs, and so maggots eat the dead tissue.
Yeah, it really produces a clean wound, but it's a little bit disgusting.
Disgusting, to find maggots when you didn't put them on there to begin with.
Found several yesterday. So, if you have a maggot, all you have to do is immerse the limb in water, and they will float to the top. I've had nurses trying to pick them off, and that can take hours.
Forever.
So.
Just put it in the water, float on up.
Yep.
Physics.
Yep.
Love it. Oh my goodness. And then wounds can just get infected after surgery. One of the metrics that are used to judge a hospital when they come in, when the Joint Commission comes in, one of them is post-hysterectomy wound infections. It's like whatever percentage, 1.5 or 2%, whatever is their normal range. So you have infections after surgeries too that have trouble healing.
Well, we see those, and I mean the population we're allowing folk to live longer, but then they have more medical problems. That it's no fault of the surgeon. It's just the fact that patients.
Yeah.
And the skin, as it ages, it's not as elastic, so it just doesn't. It can what we call dehisce. It just can fall apart because it just doesn't have the signaling to heal. Also, we're finding a lot of folk do not the absorbable suture is not absorbing.
Yeah, a lot of sutures we use are absorbable, and they're supposed to dissolve just because they're wet. It's supposed to be that suture after a month or two is supposed to be gone because it's supposed to hydrolyze.
Yeah.
But sometimes they do persist, and it's hard to explain.
So we're going to see those folk, and it's again no fault of the patient or the surgeon. It just is going to happen.
I like that. Not the fault of the surgeon. See, it's not my fault.
Right.
Right?
We see the results of things that go bad, and it's just that's what we see.
Right. You're not going to see the 99% that heal well.
Right. And so, but that's what I do. And we have as folk have gotten larger, there's
obesity is a big problem.
And fat is not well vascularized, and you need blood flow to heal. So our the other wounds we see are the patient population is increasing in size, and venous leg ulcers are very common, and people don't think about it.
All right, let's explain what that is. Blood has to go to your limb, and it has to come back.
Yes.
And normally we have veins that have little valves in them, and we're active enough. And when everything's healthy, blood goes out, it comes back. Little extra fluid comes back in the lymph, and your limb is healthy. But as we get older and larger, these veins get dilated, and it backs up, doesn't it?
And it can actually produce a wound, and people don't realize that veins can cause healing problems.
So just the pressure under that vein. We talked about a little bit about this with Dr. Ryan. He runs one of the vein clinics here. And Mike Ryan, we had a good podcast with him. So the veins can dilate and the skin over it can break down, and you just get a wound.
Yes. And those folk, you need to compress them. But we also get arterial wounds. People they only think about the heart. The heart's the classy organ. Heart arteries get clogged. Well, blood vessels in the legs get clogged as well. God is just not limiting it to the heart.
Right.
The gut and the legs can have artery trouble as well.
So you're seeing more leg wounds, and that must be horribly difficult to heal because you've got this constant pressure.
Well, and if they have artery disease, you can't compress them because you don't want to further narrow a narrowed artery. So, and a lot of disease is mixed. So you have mixed
some of
artery.
both.
Yeah. And then you have they're diabetic on top of that.
I'm going to share a story, and it will forever live with me. As a medical student on surgery, I was in on a limb amputation. Older person, that's all I remember. a dying limb that needed to be amputated. And since I was the young, strapping medical student, I got to do the saw, the Giggly saw. A Giggly saw has two handles and essentially a piece of barbed wire, and you can work up a sweat doing it. So they got everything exposed and gave the saw to student Wilshire. And, you know, it still is, it's kind of terrifying to do that, you know, but I'll never forget that. But when they were getting down to that, usually you're there with a sucker and a gauze. You're getting ready for the bleeding. And I'll never forget the resident turning to me, you don't worry about that. And it's like, what do you mean? You're about to cut this leg off. Of course, so I'm ready for the bleeding. I'll never forget, they cut into the leg and they got down to one of the arteries and it didn't bleed, Kim. Toothpaste came out of the artery. It didn't bleed. It was toothpaste coming out of the artery. That's how bad the blood supply was to this limb. And that's how they knew it wasn't going to bleed. Oh.
Blood flow is a big reason why people don't heal. And that's every leg, foot wound, we check blood flow. I've had several patients come to me that have had wounds for over a year, maybe years. They've never had their blood flow evaluated. So when you can diagnose the problem, send them to the right person, get the blood flow, and I mean, you can put anything on a wound, but it's not going to heal without blood.
It's got to have blood, nutrients, oxygen.
There's all sorts of there's like 3,500 different wound care products available.
Really?
To me, but if I can't get the pressure off the foot, if I can't get the blood flow improved, if I can't get the swelling out, a leg, foot, it's going to be very difficult to heal.
Oh, what a challenge. Oh, my goodness. So you have somebody who's diabetic, they can't feel the wound. It gets exacerbated.
They sleep in a chair because they can't breathe lying flat in a bed. Oftentimes they have back issues as well, lung issues. Welcome to my world.
Oh, my goodness, Kim. What a special person to have the interest in this and help this. This sounds like real ongoing suffering.
But I mean, we've seen folk that have had wounds for years. And when we can take care of them, and they become like family because you see them. Yeah. We like to see them weekly because debridement, that's when you scrape off the old tissue and get into new, good tissue. You get to know them, you get to know their family, you get to know their pets. And when you heal them up, I mean, we've already started getting the goodies for the holiday season. And I never was thanked for keeping someone alive on dialysis, but we get cards. And I got a Chiefs jersey yesterday from a patient. So it was extra large.
Extra large Chief. Hey, well, we come for you.
Yeah.
Use his pajamas.
Yeah. But, and my folk that work in the clinic are just so kind. Everybody has their unique skills, but it's just listening to people too. That's what we used to be able to do, but now medicine is more of a get in, get out. Yeah,
your time. You have to have so many relative value units, and they slice and dice our time, or more or less in different specialties. So you can have wounds of the feet and the lower extremities that don't heal, and it can heal and it can be caused by direct trauma, a super ball in your boot that you don't feel.
We've pulled so many things out of feet. You know, people, carpet tacks, toothpicks, little kids' toys, pieces of toys.
The occasional Lego, I bet you.
Yeah. So it's just the diabetic trauma, but then we get into the pressure injury from usually the older folk or someone who's paralyzed, and then we have to deal with getting a better mattress, a better wheelchair cushion. But Medicare has rules. If you have to have more than 2 stage 3 pressure ulcers to qualify for an offloading cushion. Well, pressure ulcers are stages 3 is a full thickness loss of your skin, and stage 4 is down to bone, muscle, or tendon.
Oh, horrible. And that's what we call a bed sore, right?
Exactly.
The vernacular is a bed sore. Someone's in bed, there's pressure on a certain spot, day in, day out. It pinches, there's no blood flow to that, or trivial blood flow there. It starts to break down,
I have a
And-
90-year-old who's always slept on their left side. They have left hip and left ankle, the outside ankle, both have pressure wounds. You're not going to get that person to sleep on their other side. It just doesn't.
Interesting. So it's just on their left side because they're a left side sleeper. My goodness. So, all right. So help me, Kim. How are you going to help heal this 90-year-old person who's set in their ways?
Well, there are offloading boots we can give them to put on at
What
night.
is that?
It's a puffy boot, actually. It just gives them a lot of offloading. Would be like having a pillow around your leg.
Ah, so it
keep
takes
the pressure
off that one spot and it kind of distributes it.
Yeah, and then we have
Offloads.
foam dressings that will distribute the pressure, say for a hip or for an ear. You know, we have a lady that has an ear wound right now. Is from
Ear?
pressure. Yeah.
From sleeping on that ear?
Yeah. Yeah.
Oh my goodness, I didn't know that could even that was a thing.
You don't see it in young folk, but in older folk, because the skin starts, it's not as elastic. It's just not as durable. So
Boy, I'm getting a healthy dose of gratitude right now, Kim.
yeah, I
Oh,
get
my
up every
goodness.
morning and appreciate the fact that I can feel my feet.
You can feel your
I
feet.
go for a run, and I don't have to deal with all our folk have problems because they have a lot of problems going on with their bodies.
Yeah, it's just one more level of breakdown. So let's move on to let's do surgical wounds because that influences me. That's my world. Okay, I generally make tiny little holes just about this big, and I almost never have a wound problem. Most of my patients fairly young.
I was going to say your patients are fairly young and
Fairly
healthy.
young, yeah. Now, I used to do big open surgeries. I'll still do one from time to time. Some of these women are obese and have huge tumors, and some of them do have some medical problems. So let's say sew up the wound and it starts getting red and starts weeping, and then pus starts coming out and it's infected. And they've got a good layer of fat. Now it's infected deep. Sometimes we have to open it up and let the air get in it, let the fluid come out. We have to pack it open. And then it closes by secondary intention. Can you explain what secondary intention is?
Yeah, sure. So there is you have a large opening in the body, and people come to me with these and say, "Why don't you just suture it up?" Well, you
Right.
cannot suture up a wound that's chronic. If it's greater than 6 to 8 hours, it's chronic.
How many
So
hours?
6 to 8.
8 hours, not
Yeah.
8 days, 8
Right,
weeks, 8
right.
hours.
Yeah.
Okay.
So then you have to wait for you want the wound to heal from the inside out, from the bottom up. And so you have to pack that wound so that you can keep when you unpack it, that's debriding that wakes up the wound to start healing. You cannot leave it just open to air because then it's going to dry out and that'll be painful. You have a good dressing, when it's not painful for the patient.
Okay, so we put the moist packs in there.
Well, when I first started out in the 90s, that's what we did. We did wet to moist 3 times a day,
Yeah.
every day, and that would take months to heal. But now you know about the wound vac.
No, I really don't.
Oh, okay.
I know that one exists. Please tell me about the wound vac. How has this been an advancement in an open surgical wound that you want to heal quicker?
So KCI came out with a wound vac in the 90s, and everyone was reluctant to try it. But it's a medical sponge that's put into the opening, the hole in the body, and then it's attached to a pump. And this is all
To suction.
a suction, so you're sucking out the drainage, which keeps you from healing. But people don't realize you're sucking in growth factors. That's what you need to heal. You're sucking in blood vessels. So you're actually creating more blood vessels.
Fascinating. And you said KCI? What's
KCI, Kinetics Concepts, incorporated out of San Antonio, Texas.
Okay, so it's a medical device company.
Yeah, they've been
Came up
bought out
wound
by
vac.
3M, and now they're their own company. And there are all sorts of wound vacs out there these days. But
Okay.
basically, a medical sponge attached to a pump. You can carry it. It's a black bag. It's about 5 pounds. And then you need to connect it to electrical
So you can ambulate, you can
Yeah.
get around a bit with
Yeah.
a wound vac.
Yeah.
And so how much faster do these types of wounds
Oh
heal?
my gosh, we were looking at months, and now you look at weeks.
Wow, months to weeks. And when a wound heals, in my experience, when it heals by secondary intention, it kind of puckers and pulls in, and
Gives a nice cosmetic.
so it looks
result.
better
Yeah.
too. A wound vac gives you a better looking
Yeah.
healed wound. Interesting, because it didn't happen very often, but when they do, and also I trained on a clinic service where people are not as healthy, and they're generally more overweight, and they're higher bacteria burden. So we saw a lot more wound problems on the clinic service back when we had those things.
There's even a throwaway wound vac that you all use, the OBs use on a C-section if you think they're going to develop seromas or a fluid collection under the incision, and it helps to manage that as well.
As well, okay.
Yeah.
So since I haven't done a C-section in 30 years, I've been out of that loop, but that's great to know.
So there's all sorts of products available for in the hospital. We don't see those products out of the hospital.
Okay. All right. So there's devices that help. So let's move on to these. You've got a bed sore in a person in a nursing home. I remember my dad in his last days was in a nursing home, and despite great nursing, and he started getting sores on his sacrum and his lower back area there, and it just seemed like people like to say, "Well, it's a never event," or "It should never happen." Well,
It does happen.
It does happen despite excellent care.
My mom was in an excellent little nursing home in Gower, Missouri. I grew up in Kansas City North, never had heard of Gower. But the 3 years she was there, it was the same staff the whole 3 years. They were kind and attentive, but she broke her hip. They fixed it. She never walked again. She was 94. She is just some dementia. And despite all of their care, she developed a pressure ulcer, a bed sore at the end of her life.
Yeah, and sometimes you just can't get ahead of it.
No, and it only takes 30 minutes sometimes to lose that blood flow and to start a pressure ulcer.
30 minutes.
I mean, we say we should be turning them every 2 hours because any more than that would be just not feasible. 2 hours,
It's not
really.
feasible.
Yeah, but we have folk that come in with they've been found down, they've fallen, they've hit their head, they're in a coma, or they just can't get help. And then there's something called rhabdomyolysis because they've been lying on their side, so they've received no blood flow to that side, and then can develop significant large wounds.
So a significant chunk of muscle
Can
run
die,
out, it can
yeah.
die.
Yeah.
Rhabdomyolysis.
Oh.
Wow. So sometimes in somebody who's incapacitated or has dementia or they're broken a hip, we just have to manage. So what would you do? Just dress it? You just cover it in antibiotic solution, or
Well, there's all
what do you
sorts
do?
there's all sorts of products, and it really depends upon if you've got just deep tissue injury is what we call it, which is deep purplish bruising, and you can see that there's likely it's going to start dying from the inside out. There's not much to do, and just manage the skin as we can. If it starts breaking down, then if there's a lot of drainage, then we put something on to absorb the drainage. If it's really dry, then we can put something on to add moisture. And all these products can be antibacterial as well. There's silver products.
Yeah, I was going to ask. I remember Silvadene for burns was really big years ago.
Yeah, not so much. Well, people still want to use it. I use Silvadene very rarely now, but it has its moments. There's a Xeroform impregnated gauze. It's called Xeroform. It's a bismuth impregnated gauze. Any heavy metal is antibacterial.
Ah, that's what's in there, bismuth.
So we use a lot of Xeroform because we see a lot of skin tears in the elderly. And in some of the younger folk, too. I mean, you can fall, and if you're on a blood thinner, you can really cause significant injury.
Oh, man. So I can see where the experience here is so important, where you can recognize or You've seen this 100 times, and you know. So, bismuth. Yeah. By the way, Pepto-Bismol.
There you go.
That's where the biz comes from. The bismuth.
Yeah.
That's why it's pink. Yeah. All right. So let's talk about these ostomies here. We've got a bowel diverted. It's coming out through the belly. So now you have bacteria, you have digestive enzymes, you have skin, you have bowel. You've got a sick person potentially. How do you manage the wound of an ostomy? I know this is probably a whole course, but give me a few minutes, Kim. What are the challenges and what are the things you can do?
Well, the devices are much better now. The appliances are much better.
The actual bag and stuff.
And the attachment to the skin. And we have barriers now to that. Ostomy may have a wound around it, but we can put barriers on it. There's something called Marathon. It's extremely expensive, but it works real well. But unfortunately, in the outpatient, the patients can't afford it. So we
What
just
is
have
that? It's a special like base layer you attach to the
It's
skin?
a base layer. It looks kind of like glue.
Huh.
Yeah.
Is it like it's like saran wrap or something?
No, it just goes on as a liquid and dries real quickly.
So it is a liquid.
Yeah.
And you paint it on or something to make a big patch of
Yep.
it on the skin? And it's called Marathon?
Yeah. We use stoma powder. We use hydrocolloids, anything to protect the skin. The ostomy nurses turn out to be MacGyvers. They just have every situation is going to be a little different.
Now, just for the younger folks MacGyver was a hero in a TV series, and he could like fix anything with a Swiss Army knife and anything, a matchstick or a paper clip or something. The joke was he could make a nuclear bomb. Some common items. So he would always find to MacGyver something is to come up with an ingenious solution.
But what we are providing just education and help for these folk. I mean, they can't go out to church. Maybe they can't go to a restaurant because the bag doesn't stay on. I had a patient that was crying because she had a blowout.
Well, yeah, it's so embarrassing.
And those patients can take an hour and a half to help out. So fortunately, we have a large clinic now with 11 exam rooms so that we can set a couple aside if that need be.
And nurses. So what kind of staff do you have there? Obviously, you've got the doctor. Do you have any other doctors that work in the clinic with you?
Unfortunately, no. The VA keeps stealing my podiatrist. So
yes, right, because foot wounds, you need a podiatrist.
So we work closely with. I was never aware of what podiatry training was. I so am impressed with how they work, their talent, skills, and how they treat their patients.
Do you know Mary Ann Manischewitz over there?
The VA stole her from me.
They stole her, yeah. She, in fact, we did a podcast with her last year on foot care.
Yeah.
So there's you as the doctor, and then do you have registered nurses?
We have 8 RNs. We have 2 LPNs. We have our hyperbaric tech. We can go into hyperbaric medicine.
That was the final thing I wanted to talk about, Kim. What a perfect segue. What is hyperbaric treatment, please?
Okay. I also want to say we have Heather Arnold, who is our nurse practitioner. So she goes out to some of the nursing homes and she does clinics.
So she'll travel to the nursing homes for wound care.
Yeah.
Wow.
Helps the nursing homes so they don't have to, because they have to send someone with the patient.
Oh, it's a whole deal transporting somebody. Yeah, much better to go there.
So we have 3 hyperbaric chambers. One is a bariatric hyperbaric chamber, meaning it can take
it's a big one.
Up to 750 pounds.
Wow. So let's explain what hyperbaric is. Hyper means over or big, right? And baric means pressure. And we're talking about pressure of oxygen, aren't we?
So we're breathing 20% oxygen here.
Okay.
Okay, so in a chamber, and it's like if folk are aware of scuba diving, and if you get the bends, you're going to go into a hyperbaric chamber. So, 100% oxygen at pressure. So we're going to go at 2.5 atmospheres of pressure. Pressure pushes physics, pressure pushes that gas bubble to get smaller and smaller so it can get into the affected tissue that's not healing.
And it's 100% oxygen.
100%.
So you're going from 20 to 100% oxygen, and you're going from 1 atmosphere normal to 2.5.
Yeah.
So I do the math. That's 5 times 2.5. That's over a 10-fold. That's an order of magnitude more oxygen at least.
So we can do a TCOM on a leg, say, and the TCOM says their oxygen in that tissue is 30. That's not going to heal. You have to have over 45 millimeters of mercury of pressure to heal.
What's a TCOM?
That's an electrode we'll put around the wound. It measures the amount of oxygen.
Oh, you can do that.
Then
So
we
you
put
have
them
a
in-
metric that you can, hey, we need to get the oxygen. What did you say, to 40?
It has to be over 40 to heal.
So it's under 40, it ain't healing.
It ain't healing. So then in the chamber we can do it, and it can go up to 500, 600, 800.
All right, so there you go. So my rough back of the envelope calculation was right. So it's an order of magnitude, over 10 times more oxygen in the tissue. Now, can you get too much?
Well, we are actually allergic to 100% oxygen. You can have a seizure. 1 in every 100,000 treatments, you can have a seizure. So then we have them breathe room air while they're in the chamber.
Interesting. So they're not breathing this hyperbaric oxygen, but how is it getting to their wound?
They are breathing in the 100% oxygen. For 10 minutes, twice in a treatment, they'll breathe air through a mask, which is 20% oxygen.
Oh, so there's a mask in there.
Yeah, that they will breathe for an air break.
They'll take an air break. Because I say if they're under pressure, because it seems to me if your head's sticking out, it's under pressure. That's not going to work.
It's not going to work. You have to breathe that oxygen in so it can go through your body. People that are putting their foot or their leg into a hyperbaric chamber is not going to work.
So it has to get in the blood through the lungs and maybe a little bit
Right.
direct in. So it's coming in from every angle, the oxygen.
So the folk that we see the most for would be diabetic foot wounds that have infections of the tendon or the muscle or the bone.
Deep infection.
Medicare makes the rules, and so you have to have a bad infection before you are. Every hyperbaric patient is audited to make sure that we're not doing anything improperly. So we have to wait for it to get real bad before we can put them in the chamber. The other thing that we get great results from is radiation-induced necrosis. Someone has had breast cancer, they've had radiation, they develop a wound in that area, it doesn't heal.
Yeah. And you can put them in the bariatric chamber.
Hyperbaric chamber.
The hyperbaric chamber. And how long? You said it's 10 minutes or it's an hour? How long do they typically go in there?
So the treatment is for 90 minutes.
Okay, hour and a
So
half.
it takes 20 minutes to get to pressure.
All right.
It takes 20 minutes to get back from pressure.
Okay.
You have your 2 air breaks. So now we're talking over 2 hours, 3 hours.
2 hours. And you're actually in this thing?
Yes, we have someone with them the whole time.
And is somebody in there with them?
No monitoring. We have 3
Oh.
chambers
Okay,
So-
so there's a nurse or a tech is outside the
Right.
chamber.
at all times. There are multi-place chambers where 6, 8, 10 people can go into a chamber and all be treated at the same time. But then you have to have an individual with them in the chamber.
So sometimes the nurse will go in the chamber with them.
If it's a multi-place chamber, there aren't that many of them. University used to have one, but they closed it down.
Assume with privacy issues, we used to have
Oh.
semi-private rooms,
Yeah.
which means a public room.
Yeah.
I love that term, semi-private. What a misnomer. So, all right, yeah, so you could have a chamber with a number of people in it if
It's
you
going to
always
be a huge,
wanted.
huge
Right.
facility to. And these things, I mean, they're built for pressure. So
Yeah, they made of steel.
yes.
What do they look like? Is it a big cylinder?
Yeah, we have acrylic so they can see out. You cannot bring anything in with you because we do not want a friction to cause a spark to cause 100% oxygen.
Oh my goodness! Oh, I can
Yes.
imagine
So
an
we are
explosion.
very, very. We go through a checklist with every patient before every treatment.
Oh
We
my
had a
goodness!
patient with dementia. She used to try and sneak stuff in. We had to just pat her down from top to bottom.
Can you bring in a book?
You cannot bring in anything
Not even a book.
that can cause a spark. We do have TVs for all of the patients. Our hyperbaric tech has a huge library now of movies they can watch. They can watch TV.
They're watching through a window. There's a
Yeah,
TV
yeah,
outside of
yeah.
it.
I would never be able to see anything because I can't see without my glasses. But yeah, people say, "Oh yeah, I'll just take a book in." No, there was an explosion in Florida. It was there are a lot of hyperbaric centers that are doing what Medicare does not approve, but there are all these clinics in all over, but Florida seems to have a lot.
Well, if you have cash-paying patients
Yes,
who
and
want it,
this was a child with autism, and the grandmother would go in. It was called a clamshell because you could fit an adult in with it. And the kid brought in a toy, and that there was a huge explosion and killed them. And yeah, so we are very aware. In our training, they show us what happens when there is an explosion in a hyperbaric chamber.
I'm old enough to remember the Apollo
Yes.
1 or 2 accident on the pad.
Yeah.
Pure oxygen, fire, tragedy. So give me some idea how much faster, or what kind of advantage do you get with hyperbaric oxygen?
Well, you're just getting that blood flow to an area. Radiation injury, which is what we see a lot of success with, that kills the cancer by just killing off the blood flow. So we're regrowing blood flow into that area. And it just doesn't affect the radiated area. I've had people say they feel better mentally, their skin looks better.
So give me some numbers, Kim. Like, you'll have 5% healing without it, and you get 90% healing with it. I mean, what kind of give us some idea just how much better for one of these chronic non-healing wounds the hyperbaric treatment
the problem
might
is
be.
you can only have there's 13 diagnoses that Medicare approves, and the two we see the most of are diabetic foot wounds and radiation injury.
Okay, let's just talk about those.
Yeah.
What type? How impressive, or how much benefit do you get having a hyperbaric facility?
Well, with our radiation injury, I think we're running around 95% as far as healing that wound.
And it was a wound that would heal, 10% of the time without it?
Yeah, or
5% or never?
Well, we have gentlemen for radiation from injury from prostate.
Yeah.
They've had bleeding and they've had trouble could be for years, and we do 40 to 60 treatments, and they're totally cured or markedly improved.
Markedly improved.
Yeah.
So let's just say in plain English, you get dramatic improvement in healing if you have a hyperbaric facility in a wound clinic such as yours with experience and knows how to use it.
Yeah.
Wow.
We see gentlemen or women that have had radiation to the jaw, and then they need dental surgery.
Oh, yeah.
So there's a Mark's protocol where you do 20 treatments of hyperbaric medicine. They have their dental surgery, and then you do 10 after the surgery. And there, it's a 99.9% chance that they're going to go through their dental surgery
without
and heal.
a problem.
Yeah.
That's huge.
Yeah.
That's huge because, I mean, the jaw infections after dental surgery, it's just bad news. It's horrible.
Yeah.
Debilitating. Think about how often you use your mouth all day, right? It's all day. Yeah, it's all day. Wow, Kim, I am learning so much from you today. You think I would know, but I don't know a lot of this. Is there anything else about wound healing that you would like people to know? Perhaps any other services you have, or new antibiotics, wraps, ointments, boots? Is there anything else that you have that I haven't covered?
Oh, we could, you could spend a week on talking about different dressings and whatnot, but basically it's we go through a process to make sure that the blood flow is good, there is no infection, there is no pressure. They are able to follow us. I had a guy today, he was using an antibiotic, over-the-counter antibiotic ointment in addition to a wound care product and I've told him many times, do not put anything on your feet other than what I ask you to put on your feet.
Uh-huh.
Or you have a patient that comes in and they're not healing. So then you go back and, oh, well, I've been using this alcohol-based product to clean my wound before I put my dressing on. Well, alcohol-based products can kill the cells that are trying to grow in there
Yeah, they're trying to
and
grow.
heal. So a lot of times it's just keeping people from doing things to themselves that they think would help but don't.
Yeah, I run into that in the fertility world. One is progesterone. Oh, I heard progesterone is good, and they take progesterone every day. I had one yesterday.
Yeah.
Been taking progesterone every day. Yeah, that's bad. It's a contraceptive. A bad idea. So we have a great community here, a great team, and you clearly have a great team at your wound clinic, Kim, and you clearly have a vast amount of experience and a love of your patients. That really is heartwarming and very impressive. So, Kim, I want to thank you so much for spending your time with us today, explaining to our audience all the incredible things you can do for wound healing and changing and improving people's lives every day. And I would encourage someone, if you've got a wound that won't heal, don't be spraying alcohol on it and using over-the-counter stuff. Talk to a specialist, talk to an expert, and get the care you need.
Thanks. They don't need a doctor's referral. They can just give us a call.
They can just give you a call.
Yep.
Fantastic.
Yeah.
Well, that's great to know, Kim. They can look you up on the internet. This is the Boone Hospital Wound Healing Center. Just go to boone.org. Or I just Googled, Kim Jamison, Jamison, Kimberly Jamison, MD, and it took me right to you and your contact information.
Well, you also got hold of me at Wilson, so.
Yeah,
Good
so
to
we
see you
also
there.
we
Yeah.
also run into each
Yeah.
other at the gym. That's
Yeah.
wonderful. Good for you. So Kim, thank you again. What a pleasure it's been speaking to you.
Appreciate it. Thank you.